This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 1142, recorded on August 22nd, 2024. I'm Vincent Draccaniello, and you're listening to the podcast all about viruses. Joining me today from not
Singapore.
New York, Singapore, Daniel Griffin. I was wondering if I should let you say it. Welcome, Daniel.
No, that works. Hello, everyone. So yes, I'm off here in Singapore, and I'm going to put my glasses on. Hopefully, David's going to get our audio up to the high quality that our listeners are used to, because I'm doing the Apple AirPod thing. So we'll see. But let's jump in. We got a lot to talk about. Actually, today's an exciting day. But I'm going to start with the quotation, and this is from Kalissa Goennawan from the book The Perfect World of Miwako Sumida. People reveal themselves in the small moments, not the big ones. And I just really like that. I mean, one of the big reasons that got me interested in medicine is I actually like people. You know, I sort of joke about it. Like, I don't like huge crowds, but I do like individuals, and I like the chance to connect and get to know people. And you know, as negative people get at times, when you really get to know people, you know, everyone has their small moment, their charm. But yes, as Vincent pointed out, I'm recording from Singapore. I'm going to be doing a few lectures here and then off to Taiwan for about a week. We'll have to figure out timing on how we do the next one. But it was nice when I got here. I was actually met by a TWiV fan. Vincent.
Nice, very
Julie
good.
Huang. Yeah, she's involved in communication. She's originally from Taipei, Taiwan. And it was interesting. She was in the Netherlands during the early days of the pandemic. So kind of interesting I'm always curious, like, you know, where were you? What was it like? And so you can imagine a Taiwanese, young professional woman living in the Netherlands. It could be isolating, right? Your family's half a world away. And then last night I had a chance to have dinner in a restaurant with really a spectacular view of Singapore. So I have some sense of where I am. And both of them were born and raised in Singapore. And so they lived through the pandemic here. And it was interesting to, compare their experiences, right? So, you know, they're both married, they have kids. One of them didn't at the time. One of them is a 7-year-old, right? So they had a child through the pandemic, young child. So just really interesting, the different experiences. I expect people are going to write all kinds of PhD theses, right, on how different countries, and then even I think sort of the human experience of the pandemic. Now, Vincent, you've traveled more than I have lately, so you've probably got a lot of accounts of different experiences around the world.
Oh yeah, and it's really, I mean, it was a life-changing event, and I don't think we appreciated it at the beginning or even going through it. But now in hindsight, wherever I go, I ask people, what were you doing? What happened? You know, how did your country deal with it? I think it's interesting to see how different places dealt with it in their own ways. And you hear it different from what we heard in the press, right? The U.S. press tends to not always give the right account. Let's put it that way.
All right. Well, so let's move into our next section. And this is a little bit of a change. And I know people had kind of wished this hadn't been a change, but mpox. And so a number of us have been following this closely, but things seem to be escalating. So we have the risk assessment for the EU EEA of the mpox epidemic caused by monkeypox virus, right? It's disease mpox, virus is monkeypox. So monkeypox virus clade 1 in affected African countries. At a high level, we read that the mpox virus, MPXV, clade 1 epidemic has been affecting the Democratic Republic of the Congo, the DRC, since November 2023, and recently spread to several other African countries, including Burundi, Rwanda, Uganda, and Kenya. The size of these outbreaks could be larger than reported due to under-ascertainment and under-reporting. I think we're sort of expecting that to be true. On the 15th of August, 2024, one case of mpox clade 1b was reported in the EU, and more importantly, they're expecting more imported cases. And so in this report, they're actually sort of giving a heads up. Couple things here. They say in countries reporting clade 1 cases, human to human transmission through close physical contact and through both sexual and non-sexual transmission has been documented. Although all age groups are represented among cases infected with clade 1, preliminary data show that infections by the clade 1b, so it's clade 1a and b, we'll go more into that, concern mostly the adult population, so 1b adults, but 1a is mostly impacting children. And unfortunately, there still are some uncertainties about the main transmission routes, transmissibility, severity, natural disease history. Now, just sort of an update on what to be looking for. Maybe this is for clinicians, but hey, it's also for everyone else. See something, say something, right? mpox symptoms usually appear 6 to 13 days, up to 21 days after the infection. And the clinical manifestation of disease includes general febrile symptoms, this distinct rash, these papules, sores on the mucosa, back pain, muscle aches, and the rash can spread quickly throughout the body within about 3 days of the initial symptoms. A couple other updates here. So I think we mentioned last week Sweden. Well, now we heard that mpox virus was detected in Pakistan. At least I was looking into this. We're not really sure yet about the Pakistan detection. Is that the West African clade 2 or the Central African clade 1? So I'm sort of keeping up on that. A report of 4 cases of mpox in Taiwan, but I want to point out that is clade 2b, right? So that's West African. But I did get I got an email from Amy. Actually, we did get the report from Thailand, and yes, this is clade 1, and so this is from the New York Times. Thai confirms its first case of new deadlier mpox version, written by Sui Lee Wee. And here we read that health officials in Thailand say that they had confirmed a case of the version of mpox that prompted the WHO to declare the global health emergency. Second time we've seen this newer and deadlier, so it's newer for us, clade 1 version identified outside of Africa. So just a little primer, what is clade 2 versus clade 1, right? So earlier outbreak, this is the one that we had the last few years, that was driven by clade 2, specifically clade 2b. And this is really a sexual contact. And it was really men who had sex with men proved to be the most at risk, the most number of cases. We did see some in children. We saw some in women. But behavioral change and vaccinations really curbed that spread. Clade 1 has 2 subtypes. We've got a clade 1a and a clade 1b. So while B may be predominantly through MSM and having sex with men sex, clade 1a appears to have spread mainly through heterosexual sex, household contact, exposure to animals. And so far, it appears that it's young children who are most vulnerable to this subtype. So a different story here. So what about this case in Thailand? What's the story? Well, Thai officials said that the infected person was a 66-year-old European man who worked in an African country with an ongoing outbreak. They don't tell us which country. The man has a home in Thailand, and according to health officials, the man flew to Thailand from Africa, transiting in the Middle East, arrived on the evening of August 14th, and the next morning he started to develop a fever, found small bumps on the skin. Now we hear from the general director of Thailand's disease control department. People should be washing their hands with soap and water, alcohol, gel sanitizer. I love these next ones. Avoid close contact with strangers. Avoid going to places where there were outbreaks, and avoid rodents such as rats and squirrels from those places. And we also, and here is, in my mind, a little bit of a game changer. We have the news release from the NIH. The antiviral tecovirimat is safe, but did not improve clade 1 mpox resolution in the DRC. This is like, hey, we've got this drug. It's safe, but ineffective. And this has me thinking of that reassuring message that our listeners, Rich Condit and I are always like, it's okay. we have vaccines, we have an effective antiviral. Unfortunately, that gets cut short here to we've only got vaccines. The antiviral drug TPOXX, tecovirimat, did not reduce the duration of lesions. It's looking at children and adults, and this is clade 1 mpox in the DRC. Now, this is a randomized placebo-controlled trial. And in the study, right, these are people in a study getting a higher level of care. There was a 1.7% overall mortality. So about 1 in 50, 1 in 60 people were dying among the enrollees. This is a little bit better than just the background mortality of 3.6 that we're seeing in the DRC. 3.6 is quite a bit. 1 in 25, 1 in 30 folks not surviving. So they're not really attributing much here to this tecovirimat. And as they say, these findings are disappointing. They give us essential information. We've really got to continue research and come up with something else.
Daniel, can I ask you?
Yeah, jump on in.
All right, so clade 1b is the current one spreading out of Uganda into other countries, right? And I mean, the idea that it's more virulent, I think we have to be careful because, you know, the kind of medical care you get in a country can determine how the outcome of an infection is. It could be very different in Uganda versus the US or Europe, for example. So I think headlines saying more virulent strain are just not useful. What do you think about that?
Yeah, I have to say, Vincent, this reminds me so much of all the reports of the different variants, like more contagious, more virulent. We're not really sure. Yeah, and so because a lot of people, and we've sort of talked about this before, they're kind of concerned about what's going on in should this get to their country? What will the mortality be? Are they going to really see 3 to 4% mortality? You know, in Sweden, in Thailand, the United States, and I'm going to suggest probably not.
But I wanted to ask you one more question, is that people here in the U.S. are saying, what should I do? And what do you answer? I mean, not everyone needs to be vaccinated, right?
Yeah, and I think that's going to be a little bit of the challenge, right? Like, so if you're going to go, like, for instance, I go to Uganda, people go to Kenya, you know, is there going to be a recommendation for travelers, right? So, with clade 2, there really was a high-risk population. So you could really target that high-risk population. I think we should have done it in a better way where people didn't necessarily have to be stigmatized. They could just be like, hey, I'd like to get that mpox vaccine. And you didn't have to be like, hey, why do you want it? What makes you qualify, right? Not everyone necessarily wants to tell you. So ideally, it would be just sort of more open. But yeah, do we start extending this? Who really needs to get vaccinated, Vincent? It's the people in the DRC. It's the people in these areas. So, you know, you think about the number of people in the United States, hundreds of millions of people. Do we really need to vaccinate everyone in the US? Do we need to vaccinate everyone in Western Europe and in Thailand? Not really. I mean, the best response to this actually is to help the people there in these countries. And if they can get vaccinated, the problem ends right there. And actually, a nice thing here is people are going down that road. And the U.S. actually announced, USAID actually said, hey, we're going to give an extra $35 million to really help with this response in Africa. So that's going to bump us up to about $55 million from the U.S. to help. And yeah, what's this going to go? This is going to go towards the vaccines. And what are those? What are those vaccines? So, you know, the main workhorse is actually the modified vaccinia ankara. And so that's the Jynneos, right? We call it Jynneos in the US, in the NEX in the European Union, Imvamune in Canada. I don't think you need to remember all these names. But this is this attenuated, non-replicating vaccinia virus. And it's probably a 2-dose. You get 1 dose, another dose 4 weeks apart. And in the US, this is approved for prevention of smallpox and mpox. Now, unfortunately, or how you look at this, the vaccine is made by this small Danish company, Bavarian Nordic. And they've got this you know, it's very nice looking. They've got their own commercial scale manufacturing facility just northeast of Copenhagen in Kvistgård, Denmark. You know, and people know I'm a huge fan of Denmark, so I've already got this on my next list of places to visit. But that's really going to be the workhorse. And so, Yeah, I think, as you point out, Vincent, who needs to be vaccinated? People in the DRC need to be vaccinated.
Daniel, is there any evidence for respiratory transmission of this virus?
Um, very minimal, right? And I was listening to our last episode where I kept saying generally, sort of qualifying the transmission.
Yeah.
There were cases of clade to West African. They'd end up in the hospital, severe disease. We'd put them in basically isolation, negative pressure room, much like we would tuberculosis or anything else. And I think part of it is you do this calculation of, oh my gosh, what a horrible disease if that gets to anyone, versus the likelihood, is it really going to spread? Is it really respiratory spread? But very minimal evidence for respiratory transmission, really contact. But that contact can be fomites. Right. So it could be bed sheets.
Mm-hmm.
It could be things that a person touched.
Okay. But not having a respiratory component is really going to limit the extent of spread compared to, say, SARS-CoV-2.
That is, it's a game changer, right? If this was respiratory, it's like COVID-19 with this just horrible disfiguring, what a change.
Yeah, I think because people are very nervous about mpox, but I think you should not worry as much because it's not a respiratory, it's not community spread and so forth.
Yeah, I have to say that some of the cases I saw, it's a fate worse than death. Some of the just disfiguring, a woman that we had there at Columbia, she had it like down through her throat and her mouth. We've seen some young men basically have to go through reconstructive surgery because of just the devastation and scarring. So, yeah, it can be pretty horrible. But fortunately, yes, we do have some understanding of the transmission, and we have vaccines, and so we really have the tools. And yes, a nice segue into COVID. We got a lot to talk about COVID. Got a number more states in that 2 to 4% when we look at the map. People told me I was confusing Mississippi and Alabama last week, right? Because I think it's Mississippi that's in the 2 to 4, and Alabama sitting right between the two, between Mississippi and Georgia. I have my states right this time, maybe. But yeah, New York, Iowa, Texas, Tennessee, Florida, New Jersey, Connecticut, Massachusetts, really a number of states that are up in that 2 to 4% of percentage of deaths due to COVID. And the wastewater is, some of these levels still rising almost everywhere. You sort of get this hint, maybe in the South, maybe in the Midwest, you might be getting a little bit of an early peak, but still really, really high levels across the country. I bring up, I brought this up in a while, but I bring this up because we're going to be talking about the new vaccines here in a moment, spoiler alert, and what is going on with the variants, right? For a while, there was a lot of talk about the JN.1, and now we're seeing lots of KP variants. So we get into vaccines, I get a little bit of a primer there on what's going on and what we're thinking about. And that brings us into hot off the press. FDA approves and authorizes updated mRNA COVID-19 vaccines to better protect against currently circulating variants. The U.S. Food and Drug Administration approved and granted emergency use authorization for updated mRNA COVID-19 vaccines, and this is the 2024-2025 formula, to include a monovalent single component that corresponds to the Omicron variant KP.2. And they say strain, but all right. So it was, I saw this hot off the press. I was trying to figure out, because I'm like a day ahead, Vincent. Did I get this news ahead of you? But no, it drops when it drops. So here's the story. So early June, the FDA advised manufacturers of licensed and authorized COVID-19 vaccines that the COVID-19 vaccines should be monovalent JN.1. But based on further evolution, the agency updated this and said, if you could do KP.2, that'd be great if feasible. And I just want to point out, this is updated mRNA vaccines by Moderna and Pfizer BioNTech. And so this really raises two questions. One is, where's Novavax? And the second is, the variant issue. So Novavax, for starters, Novavax filed for US EUA for their 2024-2025 formula in June. They're working productively with the US FDA as they complete their review, giving them whatever extra information they need. And it is interesting. Their COVID-19 vaccine is going to target JN1. And so we're going to talk a little bit about what does that actually mean. So they say they're going to target JN.1, the parent strain of currently circulating variants, and they report that this will provide coverage cross-reactivity against all the JN1 lineage viruses, including KP.2.3, KP.3, KP.3.1.1, and LB.1.1. And that'll be our protein-based vaccine option. And so what is KP.2? Fortunately, there was a nice primer that was actually just put out the last day or two by the ID Society of America. So for context here, this is all Omicron, and then several emerging variants have been given these specific names according to the amino acid changes at key sites in the spike protein. See how I changed mutations from what they had to say there? Everyone's forgotten how to use those words, Vincent. So we had those flip variants, which have an L for F change at amino acid site 455, and an F for L at site 456 in the backbone of the XBB.1.5. And then we have the flirt variants, right? So these are JN1 lineage. And so the flirt variants are so named because they exhibit the amino acid changes and F for L at position 456 and R for T at position 346. And the emerging KP1, KP3, and LB1 are all considered to be in this family of flirt variants. And this also includes all the other descendants, KP.2.3, KP3.1.1. And this KP.2 variant is also called JN.1.11.1.2. Maybe that make people feel better. It's a descendant of the JN1 variant, contains several amino acid changes that are associated with escape from the vaccine-mediated immune protection from our last year's monovalent vaccine. So there's this whole question, Vincent, about, is it going to really matter JN1 versus, the KP.2? And I have to say,
ask you that.
Yeah,
I wanted to ask you, Daniel, is there any evidence that KP1, KP2, or JN1 makes a difference, right? Because if Novavax can make JN1, why do we need KP2?
Yeah, it's interesting. Here in Singapore, they're going to actually use the mRNA. Like, for instance, I think the Pfizer is supplying a JN.1 mRNA vaccine for the fall here in Singapore. And so, we don't honestly know. I think that's the challenge. There's this idea, let's get as close to like the starting line as we can because we expect things to continue to change. But a lot of what drives the changes, right, are antibodies in people, and then people get exposed, and then there's this selective pressure. It's not like the virus is happier with all these changes. It's just these are fitness within a context changes. Yeah, so I don't know. And what I would love to see, in all honesty, and we're going to get on this because we've got some other articles coming up, but a really nice comparison of Novavax efficacy, for hospitalization, disease, compared to the different mRNAs. And I would love to also see at a place like Singapore, where you actually have the JN1 mRNA, right? So you can see how much is it head-to-head difference with, the mRNA versus the protein platform versus which variant you chose to target in your vaccine. Imagine that, asking for science. All right. But should we get our vaccines, right? What is and here we have the article, what is the economic benefit of annual COVID-19 vaccination from the adult individual perspective, published in JID? So this is, does getting that COVID-19, does it benefit you financially? And so here, these researchers developed a model, a Markov model, representing the potential clinical and economic outcomes from an individual perspective in the United States of getting versus not getting an annual COVID-19 vaccine. So what is a Markov model? Well, very simplified. Don't yell at me, statisticians. So this Markov model is a model used to predict certain types of changing systems. So things are changed, but you assume that you have a current state. You kind of forget about where things were going before. You say, here we are today. If I make one change, what's going to happen? So that's our Markov model. Now, using their modeling, they suggest for an 18 to 49-year-old getting vaccinated at its current price, they say $60. If you had to pay that yourself, it can save the individual on average $30 to $603 if the patient is uninsured, and $4 to $437 if the patient has private insurance. Apparently, depends on how good that insurance is. As long as the starting vaccine efficacy, you ready for this, against infection is greater than 50%. And the weekly risk of getting infected is 0.2%, corresponding to an individual interacting with 9 other people per day, right? So you get to calculate how gregarious are you, like how much do you spend? And then if you've got 50 to 64-year-olds, the cost saving increases to $111 to over $1,000. And it's up to like 1706, and this is for people with and without insurance. And this is not about, are you going to die? This is looking at the whole issue. Are you even going to get infected? Are you going to end up going to see a doctor? Are you going to end up in the hospital? And the risk threshold, of course, changes by how gregarious. So sort of an interesting, I think they're trying to make this argument that it's in your best interest financially to go ahead and get that vaccination. But now, how good, I guess, were the current vaccines when we followed them out? So the XBB vaccines. So we have the article, Early COVID-19 XBB.1.5, Vaccine Effectiveness Against Hospitalization Among Adults Targeted for Vaccination. And this is the VBIS Hospital Network Europe, October 2023 through January 2024, published in the journal Influenza and Other Respiratory Viruses as a short communication. So here we get the results of a multi-center test negative case control study covering the period from October 2023 to January 2024 among adult patients aged 18 or older, hospitalized with severe acute respiratory infection in Europe. And they provide early estimates of the effectiveness of the XBB COVID vaccines against PCR-confirmed SARS-CoV-2 hospitalization. So that's disease. I like this as an endpoint. Vaccine effectiveness was, I'm going to say, only 49% overall, ranging between 69% at 14 to 29 days and 40% at 60 to 105 days post-vaccination. The XBB vaccines conferred protection against COVID-19 hospitalization in the first 3.5 months post-vaccination, with a vaccine efficacy of greater than 70% in older adults. I think we're just seeing kind of a replay here, right? These current boosters, remember you're comparing this against a background of immunity, right? This is not the same metric we had in the early days when you said, oh, but this is a 95%. Well, it's, this is 49% and 70% compared to a background, getting the booster or not. But we're also seeing that efficacy drop as time goes by.
So, Daniel, is the drop due to waning immunity or a new variant or the lack of good memory induced by these vaccines? We really don't know. And so we're just assuming that neutralization assays tell us everything, and we make a new vaccine, every 6 months, which it seems to me is not driven by any science.
The big challenge is also the uptake, right? So, we keep going down this road. We've got a lot of focus on these neutralizing antibodies. And do we get as much focus on the T cells? But I guess here we're seeing, right? Over time, are we losing this because of a mismatch with the variant, or are we losing this just because that's what happens over time with these vaccines?
Yeah. Yep.
All right. So the second study to look at this issue is COVID-19 in pregnancy retrospective cohort study. And these are the results of a retrospective cohort study looking at pregnancies in Northwest London general practice. This is a nested case control analysis. And this study included 47,000 pregnancies among 39,218 women. 57% of the pregnancies, women had at least one dose. And here's a comparison. Women admitted to the hospital were much less likely to be vaccinated, only 22% of those, versus the ones that stayed out of the hospital with the majority, 57%. And Novavax, the article, the Novavax heterologous coronavirus disease 2019 booster demonstrates lower reactogenicity than messenger RNA, a targeted review published in JID. This is really this question that we keep talking about. Like, people are like, I really want to get another one of those vaccines. I was like down for a day or two. Is there something I can get that's not going to do this? So I think this is pretty timely. They're going to look at reactogenicity, the occurrence of any local systemic side effects, because this really plays a part, particularly now. Like early on, people are like, just give me that vaccine, whatever happens, I want to have that protection. And after the second, then people are kind of like, yeah, I don't know anymore if it's going to be a cost to me. And we talked earlier about a financial cost, maybe that's $60, but here's that, impact on your life. Like, hey, I get this on a Friday afternoon and then Saturday it's just a wash. So here the researchers conducted a targeted review of the reactogenicity of authorized approved mRNA and protein-based vaccines, Novavax, and they found that the mRNA-based boosters showed a higher incidence and an increased severity of reactogenicity compared to the Novavax protein-based. So they actually talk about, remember, this is kind of an analysis putting stuff together. So they're looking at a number of studies, and one of the studies was from the National Institute of Allergy and Infectious Disease. And we hear the incidence of pain, tenderness, swelling, erythema, fatigue, malaise, headache, muscle pain, or fever was higher in the BNT group or the Moderna group compared to the Novavax. So really evidence suggesting that the Novavax as a heterologous boost is just a little easier to take. They've got a nice graphical abstract where you can see a little bit of this.
Daniel, I think that many people still do not trust the mRNA vaccines. And so having a protein-based vaccine, a more traditional vaccine, is a good option. I think that's the strength here, and why you and I are bullish on Novavax for that reason. What I would like to know, though, is whether you get more durable immunity with protein compared to mRNA. Right? That's something we don't know.
Yeah, I think that's correct, right? There's a lot of ideas, right? But we always want the science. Like, is one really better than the other? Well, what's great is choices. And you are right. There's a lot of people that still have concerns about mRNA. Oh, it's gene therapy. And so it's great to have this other option. So, yeah, I'm a little worried about the delay and when Novavax is going to get to market, right? Because the message is very clear from all the public health resources. We're encouraging everyone as much as possible to go ahead and get the updated shot, whether it's important that it's updated or not, whether it's just important that people get the shot because you get this rise in protection. As we talked about with measles, is there some sort of, population benefit maybe we're hoping we'll get from that? There's some sort of decrease as far as impact on the healthcare system. So across the board, so boy, particularly, we're in the middle right now of a rise, right? So that normal idea, wait till like early November, it'll protect you against the sort of Christmas, December holiday, January holidays. The Jewish holidays, Hanukkah, I guess. And what are we forgetting? What other holidays are going on in December? Kwanzaa. Like my youngest brother celebrates Kwanzaa. So, right now for the oldest among us, we're just, hey, go ahead. We're in the middle of a wave. Get a shot now. You probably got to, get recommended get another shot after New Year's. For folks that, just had it, right? This is important. If you just had it 3 to 4 months, you should wait, and then consider getting it. And for a lot of folks, they want to give, Novavax a few extra weeks. People starting school, people about to travel, things like that might impact the timing and choice. All right, passive vaccination. We have PEMGARDA. With the changing variants, we had said 70% risk of reduction. There's a preprint out there from David Ho's lab, sort of questioning with neutralization antibodies, is it still as effective with the KP2? And let's move right into the early viral phase. And we keep hitting on this, NIH treatment guidelines, ID Society guidelines. You got to understand this disease. The first week is the viral replication phase. That's when we can do the most good. So number one recommendation is Paxlovid for 5 days. I know people say like 5 versus 10. Remdesivir, we studied 5 versus 10. 5 was as good or better. We have yet to prove that any further than 5 days is worth it with the Paxlovid. There are drug-drug interactions. People complain about that metallic taste. I shouldn't say complain. They report, they share. Number 2 is remdesivir, right? That's the 3-day infusion. Molnupiravir, convalescent plasma in certain cases, and isolation, because you can spread it to others. And remember, 85% during the first 5 days, but we still see spread day 6, 7, 8, maybe a little past there. And then 2, the early inflammatory week. And I think people keep needing a reminder here. COVID has not turned into a 5-day illness. Right, you got that 5-day viral replication phase, crummy fever, and then boom, it's that second week. This is what I worry about, right? This early inflammatory week. This is when people can feel rotten. This is when they get hypoxemia. This is when people can end up in the hospital and not survive because of these things. And what do you do during that second week? There really isn't a lot, right? You've missed your window. It's that first week we can do the most. Steroids at the right time in the right patient. People can take, Afrin, they take Mucinex, they can take Tylenol. If they're going to take ibuprofen or something like that, then, let's be careful that they're not on a drug that interacts. Anticoagulation guidelines for those in the hospital, pulmonary support, remdesivir, maybe some immune modulation. All right, and now we have a little bit here in our late COVID section, the late phase past long COVID. And this sort of trying to decide, does it go here, does it go in children? But we have the article characterizing long COVID in children and adolescents published in JAMA. So here the objective was to identify the most common prolonged symptoms experienced by children, 6 to 17. We're going to break them down into school age, 6 to 11, and adolescents, 12 to 17. Kind of hoping that some of those 12 to 17-year-olds are still in school, but and looking at how they might cluster into different phenotypes. And so these results come from a multi-center longitudinal observational cohort study, the RECOVER Pediatric Observational Cohort Study, RECOVER Pediatrics. And participants were recruited from more than 60 U.S. healthcare and community settings. Now, ultimately, in this analysis, we've got 898 school-age children, 751 with previous SARS-CoV-2 infection, and 147 without. Mean age 8.6, 49% female, 11% Black or African American, 34% Hispanic, Latino, or Spanish, 60% were white, and the median time between the first infection and symptom survey was 506 days, right? So this is really far. 506 for the school-age children, 556 for adolescents. In models adjusted for sex and race and ethnicity, 14 symptoms in both school-age children and adolescents were more common in those with the SARS-CoV-2 infection than those without. Amazed, I keep finding folks that have never been infected. And these symptoms affected almost every organ system. And they're working on creating this index. And this index, if you go through it, it emphasizes neurocognitive impacts, pain, gastrointestinal symptoms. In school-age children, change or loss of smell, taste, pain, fatigue, malaise in adolescents. And they end up defining these 4 past symptom phenotypes. But what are the big takeaways here? This is an article we're spending some time on. The big takeaways are that we see long COVID in kids, right? There was a recent retraction of an article suggesting that we didn't, which was flawed in so many ways. So we see long COVID in kids, and it's different from what we see in adults. And it's even different between the adolescents and the younger children. All right. So I'm going to wrap up before we get to emails with no one is safe until everyone is safe. I'm hoping we would pause the recording right here, go to parasiteswithoutborders.com and click donate. Even a small amount helps. We're doing our Floating Doctors fundraiser, where August, September, October will double your donations up to a potential maximum donation of $20,000.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Edward writes, I've been a longtime listener to TWiV and Daniel's clinical updates. I applaud the evidence-based approach you have promoted. Your insights have been of great value to my clinical practice, also personally. However, I have to take issue with Daniel's interpretation of Paxlovid rebound. Daniel has repetitively stated that the Paxlovid rebound is a manifestation of the T-cell inflammatory response to the infection. While this is teleologically makes sense, I cannot find literature to support this position. Rather, when searching PubMed for Paxlovid rebound, I find only one article theorizing that viral dynamic models explain the rebound phenomenon based on the idea that 5-day Paxlovid treatment started near the time of symptom onset, reduces the depletion of target cells, but does not fully eliminate virus, thus allowing the virus to rebound once treatment is stopped. According to an article published in the Annals of Internal Medicine, November 2023, viral rebound occurs in 1 in 5 patients receiving Paxlovid. The accompanying editorial goes on to speculate that the most compelling explanation for the relationship between NR treatment and COVID-19 rebound is that 5 days of treatment at the current dosage is inadequate. The editorialists refer to the mathematical model mentioned above and state that early treatment with NR leaves too many target cells susceptible to infection. Incomplete suppression of replication-competent virus would be expected to lead to rebound. I would appreciate your comments. And Edward Gold is chairman of medicine at Pascack Valley Medical Center.
Okay. So this is, we got to keep having this discussion, and I think this is fine. So, the first thing you want to ask is when people got on the news and they said, oh, I had Paxlovid rebound, my patients have Paxlovid rebound. Now, what were they talking about? Were they talking, were they doing quantitative PCRs every day on their patients? Or were patients just saying, I started to feel better, and then boom, that second week, I really felt crummy. As a clinician, you're talking about the latter. You're saying, I've got a patient and they said, hey, I was starting to feel better. And then, oh my gosh, that second week, I just got hit like a truck and I feel crummy. One is just to point out, we've been seeing that dynamic to this illness since the early days. A week 1 with viral replication, a week 2 with the cytokine storm, the inflammatory phase. Now, so that I have to say is completely different, right? The week 2, the return of symptoms that we see with and without Paxlovid. And actually, the severity of those symptoms during week 2 is actually reduced in people that get Paxlovid. Now, the second question is, what about the viral genetics? What about those PCRs that I check in the nose, right? And so, what is the goal of Paxlovid? Is the goal to completely get rid of viral replication? I mean, that seems great from a science standpoint, but as a clinician, we're taking care of patients. So our goal is not necessarily to get that PCR down, but it's to make our patients feel better. It's to make our patients stay out of the hospital. It's to reduce mortality. It's to reduce the chance you end up in the ICU or the chance you end up on a ventilator. 5 days of Paxlovid does that. 5 days of Paxlovid, when we started with the EPIC HR, close to a 90% reduction in people progressing to end up in the hospital. And then the people who got Paxlovid, the people who didn't, people get Paxlovid, 0 folks ended up on ventilators, 0 folks died. You actually had a number of people in the control group that ended up on ventilators and ended up dying. So that's a big thing. The second is, have we actually looked at this? And by we, I mean Pfizer. Has Pfizer compared 5 days to 10 days as far as, anything that matters as far as patient outcomes? And they presented this data at CROI, where what they did is they took, they went, which I thought was low-hanging fruit. I was surprised they didn't show it. They said, let's take immunocompromised people and let's compare 5 to 10 days and look at outcomes. And you know what? No difference, no benefit to the 10 days. So we've looked at this. And I think what ends up happening is when people talk about Paxlovid rebound, they're confusing what they might see when they chart out a bunch of PCRs. It starts up in the millions and you might get a little bit of a bump into like 100,000 and oh my gosh, that's failure. But is it really failure? The failure, would be as if our patients had issues. And Paxlovid in the unvaccinated, and now we see data in vaccinated, has a really tremendous job of reducing the risk of progression to hospitalization. And as we're seeing with the vaccines, right, 50% reduction in progression to hospitalization. You still have a lot of folks out there that are going to end up in the hospital. They're going to end up not surviving. The data for this last year, we saw over 1,000 people a week still dying of COVID in the US. Paxlovid is going to reduce that number even further down.
I would suggest that searching PubMed for Paxlovid rebound is the wrong search term.
I was like, are there UFOs? I looked and oh my gosh, look what came up. So,
all right, DJ writes, I'm a retired band director who does a lot of substitute teaching in schools with lots of newcomers to North America. In the run up to COVID, I was out buying hand sanitizer and cold medicine already in February. What precautions should I be taking regarding mpox? It's not spread respirally, is that a word? But in the band room, there's plenty of spit around. Hand sanitizer, gloves, I would appreciate your thoughts. Incidentally, I'm triple vaxxed and a novid, at least as far as tests can confirm, which I laughingly chalk up to having been exposed to every possible germ during 40 years of teaching little spit factories.
Oh, and I like that D.J. And Gay as far as his last name. So, this is reasonable, right? I mean, you're concerned about it. You're hearing about it. I'm in a school. There's all these kids. As the band teacher, you're going to be, in and out. I see like license stuff in some of our, musical teachers, right? So like right next to someone and they're teaching them piano. Or, you're sort of describing, right, a lot of these brass instruments and all this saliva flying everywhere. So yes, as Vince and I talked a little, no evidence that you're going to see respiratory spread of the mpox disease, of the monkeypox virus. Wash your hands. That's what we're recommending. People really start to spread this disease when they have lesions. So I don't think you need to go overboard with hand sanitizer or gloves. This would be a situation where you probably have someone nervous like this and like, hey, can I just get the vaccine and worry less? Reasonable consideration.
Ellen writes, twice now I've heard that doctors are telling their patients that Paxlovid is not that effective against the current strains of COVID for people over 65 with or without underlying conditions. Is this true? If not, where are doctors getting this information? These are reputable doctors in progressive cities who I wouldn't think are susceptible to misinformation.
Yeah, so Ellen, let me answer this. Unfortunately, yes, reputable doctors in progressive cities are still susceptible to misinformation. So here's the way to look at it. So early on, when we do the EPIC HR, the EPIC high risk study, so let's say you've got an individual, they're 65 years of age and older, you've got a 20% chance of ending up in the hospital. You give them Paxlovid, and that 20% goes down to 2%, right? So that's huge. No one dies, no one ends up on a ventilator, that's huge. So now you've got vaccines. And we're seeing with the vaccines, right, that 20% is now maybe down to 10 or even less. We'll use 10 because the math's a little bit easier. So 10%, you're just, most of your patients, 90% of your patients are going to be fine. They're not going to end up in the hospital. There's a big psychological difference there. And now you give them Paxlovid and that 10% goes to 5%, let's say. So now it's not like your anecdotes are going to give you the feedback. But Paxlovid still works, right? We have now hundreds of real world studies on efficacy of Paxlovid. And the big thing here is that, people have immunity, people are vaccinated, they have prior infection. What can we do to address that? Over 1,000 deaths per week in the US from COVID-19. The big common denominator here is they're not being offered Paxlovid. And then when they die, the doctors seem to sort of shrug and say, oh, well, this or that. But come on, we can save hundreds and hundreds of lives each week if we do a better job prescribing Paxlovid. And as far as changes in the virus, right, the changes we keep talking about are changes in the spike protein. The Mpro, the target of Paxlovid, has not changed, and this drug continues to be effective.
Rich wants to know, is there any indication that long COVID can occur after an asymptomatic infection?
So, Rich, unfortunately, yes, a number of folks with long COVID had asymptomatic infections. And sometimes we sort of trace back in history, oh, everyone else was sick, everyone else tested positive, you felt fine. Here we are 3, 4 months later, and you've got sort of the classic historical, biochemical, physiological abnormalities that we see in long COVID.
And finally, Carrie writes, I may need to travel to urban and rural Kenya for work. I'm a middle aged female, mostly healthy except for a type of autoimmune arthritis. So any infection can cause a flare, which can be debilitating. I'm looking forward to getting the updated Novavax vaccine when it's available, given the latest mpox outbreak, and potentially staying in hotels with questionable housekeeping, being on planes, crowded locations, having limited access to quality health care. Getting an mpox vaccine and traveling with Paxlovid seem to make sense. What is the optimal sequence of getting Novavax and mpox vaccine to ensure an effective immune response? So far, I'm not on biologics, so I think I would generate an immune response to both vaccines.
Yeah, so with you, there's a few subtleties here. So one is we have not done any studies where we give people Novavax and Mpox at the same time, but we do have a lot of studies where we go ahead and give people multiple vaccines at the same time. Maybe they get the flu and they get the COVID shots. So we don't know exactly, but I would not think sort of our understanding of vaccines that there would be a problem getting the Novavax and the Mpox vaccine at the same time. Logistically, there may be kind of a little difference in when it happens. I'm not sure there really is much that we know about the optimal sequence of the Novavax and the Mpox. There might be a priority, right? Much more likely to get COVID than you are to get Mpox. So, sort of prioritizing the Novavax vaccine, seeing how you do, and the other sort of twist for you, right, is you have some immune issues, the autoimmune arthritis. Potentially could get a flare. So for you, it may help to space them 2 weeks apart, just so if there is any kind of a reaction, you have some sense of what was responsible for that.
That's TWiV, Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.